Hold on, please, just a moment. Okay.
All right. Well, so thank you to our presenters for being part of this poster session today on COVID-19 related pragmatic research. And so our process that will follow is about 4 to 5 minutes for a poster presentation, followed by a few minutes for questions, and then we'll move on to the next speaker. Maybe. It's not letting me advance my. Thank you. All right. Stephanie, I'll turn it over to you to give us an overview of your poster.
Sure. So I'll describe today a pragmatic pilot study that we did early in 2020 to evaluate the effect of prone positioning in hypoxic patients with COVID-19. And we did this sort of unique pilot study that had sort of an implementation focus. So we framed the pilot study as if it was an implementation study where in a randomized controlled trial, a definitive trial was the thing to be implemented. And we measured in the pilot study, our main outcomes were implementation outcomes relevant to the conduct of a definitive randomized controlled trial. So just a little background about prone positioning. We obviously were early in COVID-19 and still we were looking for things that we could do to benefit these patients. We didn't have a lot of treatment available to us. And we knew that in mechanically ventilated patients, prone positioning or flipping over to your belly would improve oxygenation. There's anatomic and physiologic advantages to being on your belly that improved oxygenation. But what was not known is whether that would benefit oxygenation in patients who were not mechanically ventilated. So there was sort of a global desire to study this in a randomized controlled trial fashion to have some definitive evidence for that. And within our own healthcare system, we wanted to study that rigorously as well. But prior to doing an RCT, we had this kind of realization that prone positioning or implementing prone positioning is a complex medical intervention. It wasn't as simple as giving somebody a medication. There are all these complexities, and we felt like studying this systematically with a pilot study to determine whether or not a definitive randomized controlled trial was possible and what type of things needed to be considered in the conduct of a randomized controlled trial. So our pilot study, we took 5 medical teams at in our healthcare system and randomized them in a cluster randomized strategy. So 3 teams were randomized to a prone positioning strategy and 2 teams were randomized to a usual care strategy. Patients on the medical teams were randomized to whichever team they were admitted under. And in the prone positioning strategy group, the physicians got education about prone positioning. They got handouts to give nursing and to give patients to facilitate understanding prone positioning and how long to be in prone positioning and that kind of thing. And then we monitored outcomes over 48 hours. In the meantime, we did interviews of 8 clinicians and 6 patients to really kind of get at some of these implementation outcomes that we were measuring. Over the course of the study, we enrolled 40 patients in both the usual care and the prone positioning group. And I'll spend most of the time kind of talking about outcomes. So on the far right of the poster, you can see sort of the oxygenation outcomes. And we did end up with some separation of oxygenation outcomes in the prone positioning group. Patients numerically had a better oxygen saturation compared to the usual care group, and they spent less time in the kind of hypoxia range. But the main results, I think, were here in these implementation outcomes. And these are things that we got from a mixed methods analysis using both some of the quantitative results and qualitative results from those interviews. And one of the main things we found was acceptability of doing a randomized controlled trial evaluating prone positioning. And most of our physicians felt like randomizing to a control group was not cool. So there was this perceived lack of equipoise where the clinicians said they wouldn't feel comfortable enrolling somebody in a study where they might get put in a control group because they felt like the harms of prone positioning were so little and the potential for benefit was so high. So that was really important. It actually showed up in our fidelity measure because half of our patients ended up with protocol violations. So half of the patients were either randomized to the usual care group and got proned anyway because the physicians in the usual care group had already sort of this intervention already diffused into usual care. And so they were using it anyway. And then half of the patients in the prone positioning groups were not able to tolerate the prone positioning and ended up, sort of ending up with a usual care type strategy. So some of the other outcomes we looked at, again, appropriateness. So a lot of the physicians felt like prone positioning had already sort of become usual care and they weren't willing to give patients, withhold it from patients. Our feasibility measure, only 2 of the patients had any documentation of how long they were put in prone position. So from a measurement standpoint, we found that to be a big challenge for a randomized controlled trial. And then the idea is you stay prone for as long as possible, but the recommendation is that the patient stays prone from 12 to 16 hours a day, and none of our patients were able to do that for a variety of reasons. Comfort, because they needed to do other things, receive medications or do physical therapy, but we found that 0 of the patients were able to do the recommended protocol. And then finally, we found some equity differences with lower rates of adherence to the prone positioning among Black participants compared to white and non-Black Hispanic participants. So the overall kind of interpretation of this, there were lots of nuances in designing or in conducting a definitive randomized controlled trial to test this intervention. And we framed it sort of with implementation outcomes that I think was a really effective way of getting at the barriers to conducting a high quality randomized controlled trial. And actually, in the end, our healthcare system decided not to do a randomized controlled trial, but to study this with a quasi-experimental design using regression discontinuity type approach, rather than trying to do a cluster randomized trial due to the limitations that we sort of found in this pilot study. So I went through that super fast, but I'd be open to any questions that you guys have.
That was a hey.
We don't really have time for questions. We need to go on to the next one. We did get started, I guess, a little bit late, but just want to thank you.
Sure.
And it seems like a really important project. And sometimes it sounds like, the intervention itself that we're testing isn't terribly pragmatic. You talked about sort of lack of comfort and tolerability.
Yeah.
And that's pragmatic. And so even if you can identify effectiveness of treatment, given what people are willing to adhere to, what they're able to adhere to, I think there's still value in that. Any very quick comments?
Yes. So we did think that this was worth studying. We just felt like the traditional setup of usual care versus treatment group and looking for separation and outcomes there wasn't going to be able to detect a difference, primarily due to diffusion of the intervention into usual care. But yes, absolutely. I think if people could have tolerated an hour or 2 and it was still beneficial to them, then that would have been a meaningful result.
All right. Let's go to the next presenter. Can you advance, Mike?
Yes, sorry, I was muted. Okay, and so we will proceed on to our next presenter, Dr. Joanne Shoup.
Great, thanks. Hello, everybody. I'm Joanne Shoup, and I'm a project manager at the Institute for Health Research at Kaiser Permanente, Colorado, and a scientific team member of the Breathe Well Asthma and the Improve projects. And our poster today is situated within the asthma and COVID arena. And what we wanted to do is look at the equity of reach. And so we use the REAIM framework. So today I'm discussing our poster. It's titled Assessing the Equity of Reach, Virtual Medical Visits Among Asthma Patients During the COVID-19 Pandemic. So we were really concerned at Kaiser Permanente that people weren't coming in for needed and necessary healthcare visits. And asthma is one of these things where you can have an exacerbation within asthma and it can be a bad outcome. So we wanted to assess that using our medical records and electronic data systems. So overall, the global pandemic really caused this rapid spread of severe acute respiratory syndrome, coronavirus 2. And what this did was necessitate a really rapid shift from in-person to virtual care deliveries. And subsequently, it impacted healthcare routine practices as well. Within healthcare, so there was this rapid shift from in-person to virtual visits. This required swift adaptation of patients, of healthcare systems, and medical personnel. So there's known deleterious outcomes such as hospitalization and death that may have been associated with not receiving early treatment for asthma exacerbations. Additionally, existing health disparities may have created even a wider chasm of care for underrepresented racial and ethnic minority groups. So virtual health may have helped to bridge the asthma healthcare access gap, but the extent that this varied across race and ethnicity is unknown. So we wanted to evaluate Kaiser Permanente's use of virtual visits across race and ethnicity. This assessment is actually a smaller part of a larger assessment we're doing for looking at our virtual visits capacity within Kaiser Permanente, Colorado. Specifically, we're looking at asthma and asthma exacerbations and lots of impacts on care. And there's other groups that are looking at other health conditions as well. So Kaiser Permanente is an integrated healthcare system, and it already has had an existing infrastructure for virtual care prior to the pandemic. Our research question was, did a shift in virtual visits adversely impact access to preventive care among demographically diverse asthma patients? So we evaluated this access to virtual visits by using the REAIM framework, specifically the dimension of reach, to examine the equitable reach and representativeness of virtual asthma visits. As you can see in the poster, our population included patients diagnosed with persistent asthma within a single site integrated healthcare system. We had existing infrastructure for virtual care. This included email, telephone, video visits, or chat with the doctor. And this was prior to the pandemic. We determined income and education using census tract geocoding. We categorized ethnicity as Latinx and race as Asian, Black, African American, white, other, which included rolled up Alaskan, Native American, Indian, or Native Hawaiian, other Pacific Islander, and then unknown. To assess the association between race or ethnicity and use of virtual visits for asthma care, we used logistic regression and adjusted the models using covariates. We defined the dependent variable as visit type, as in-person only versus virtual visits for those that had one or more visits within the healthcare system or any hospital. So what did we find? We found that 5,796 asthma patients 60.6% used virtual care during the pandemic period from March through October 2020. So race or ethnicity were not significantly associated with higher or lower use of virtual care visits during the pandemic. And then looking at the table here, you can see that, the confidence intervals crossed 1. And so there was no higher or lower usage. So there are several limitations to highlight within our research. This is only conducted within one integrated healthcare system of employed and highly educated membership. Comparing any versus no virtual care may underestimate the extent and reason for use. So we really looked at this as, any versus no virtual care visit, and type of virtual care visit is something that we're looking at now.
I think that's a really good point you're making, is it wasn't necessarily asthma care, but they got some care. You don't know exactly what kind of care, and that your audience was really, you had a captive audience in some ways, right? Because of the way Kaiser set up. It would be really fascinating to hear and learn how other studies that race and ethnicity and reach compare to yours. You might be the gold standard of the healthcare system, and then it will be interesting to see how that plays out.
Yes, and we acknowledge that, and know that although it's reassuring to us as a healthcare system that there weren't differences, we definitely acknowledge that there could be significant differences in other healthcare systems who may not have been set up and had to scramble and educate their medical staff for these types of virtual care visits and how to do it, and then educate their membership. In addition, our membership is very exposed to getting outreaches electronically and in different ways and modes already. But we did find that, for REAIM, the dimension of reach really helped us think that through, right? We wanted to make sure that we were assessing what was important to public health and to other integrated healthcare systems, as well as other public systems. And so I think that dimension helped us think through what we really needed to look at and assess.
It's a wonderful framework.
Yes, yeah. And within an integrated healthcare system, we already had like what we've said, we had existing virtual visit options. And so it didn't differ. That's reassuring to us, but it really is imperative to assess virtual healthcare access across multiple health conditions. So within our system, across health conditions and organizations without existing capacity for virtual medical care, and those with access barriers. So acknowledging all of that.
Joanne, thank you very much for your presentation.
Sure. Thank you.
I think we're going to move on to the third option now. The common denominator in all of these is the rapid pivot that everyone needed to make in a different environment for a different reason, but everybody was pivoting for sure. So we've got our next poster up. You want to take it away?
Yes, I just want to apologize for joining late. I was having some technical issues, which is kind of goes perfectly with what I'm about to present. So first of all, thank you for having me here. I am the project manager for the Kids Face Fears study at Boston Medical Center. Kids Face Fears is a multi-site national study with sites in Boston, Miami, Seattle, and Baltimore. The study is designed as a pragmatic RCT, and our primary objective is to evaluate relative effectiveness of two modes of delivering cognitive behavioral therapy to treat childhood anxiety in children ages 7 to 18. And our two comparators are therapist-led cognitive behavioral therapy versus self-administered online web-based behavioral therapy or cognitive behavioral therapy. And our participants are identified in pediatric healthcare settings through anxiety screenings and direct referrals from their providers. And the treatment is conducted within behavioral health specialty clinics at these sites. Obviously, COVID-19 posed a huge barrier for our study, and basically 5 months into recruitment, we were hit with COVID-19 and kind of had to reevaluate how to carry on this study safely. So the study was momentarily paused. And during that time, we continued to meet with our site investigators and our coordinators on a bi-weekly basis to get updates on COVID-19 related policies from the hospital, from the state, from clinics, and from the IRB. They also provided updates on how the clinic was progressing with treating anxiety. Obviously, a lot of anxiety treatment for children is office-based, and many moved to telehealth. And so we were kind of assessing the barriers to continuing our study and continuing treatment for our participants. Along with kind of assessing the barriers with our research team, we continue to have scientific steering committee meetings and study advisory committee meetings every 6 months. And both these committees are made up of very experienced researchers in the field of pediatrics, mental health. It also included providers and policymakers. And we basically presented our findings in regards to barriers, got feedback on strategies that have been successfully implemented in their research or clinical settings for both recruitment and for carrying on treatment. Because our recruitment, it partially depends on providers and provider engagement. It was really important to for recruitment success to think about what providers were feeling during this time and the feeling of being overwhelmed and how to really address that. So getting like feedback from clinicians on the ground was a really important part of like, how do we figure out how to keep providers engaged and prevent burnout and how to support them. So they also provided insight as researchers on what data points to collect for both therapists and for our participants. In this study, therapists are also participants. We're also collecting data on their experience delivering cognitive behavioral therapy using an online and office-based approach. And you know, given the change in our environment, it became really important to collect some data to evaluate the significant impact that COVID-19 has had on mental health and general well-being for both participants and therapists. We also met with our patient and family advisory council, and that was especially valuable in grounding our research and ensuring that all our procedures were patient-centered. We discussed potential recruitment strategies, got feedback on their attitudes towards telehealth and general insight on how families and children were dealing with mental health issues during this time and what treatments they needed. And after these meetings, our study team would assess the feasibility of recommendations from our advisory committees, make necessary adjustments to account for site differences, and create a plan for implementing these changes. And on this poster, I've highlighted a few key changes that were made. The major change really being the inclusion of telehealth in our therapist-led comparator arm. At the outset of the study, therapist-led was purely office-based. So we expanded that to include telehealth. Some clinics continue to have in-person therapy throughout the pandemic, and some moved to in-person delivery over time. So it became really important to basically have the flexibility to go to the office or do therapy via Zoom. A lot of folks were feeling Zoom fatigue or struggled with finding private spaces in their home. And that was especially important for adolescents and children to really engage with therapy. They needed to feel like they had private space. So having the flexibility to do in-person or online was important. And obviously for those who weren't comfortable going back into the office, still having Zoom as an option was important. And because of that, we included a hybrid of telehealth and office-based delivery in the therapist-led arm. every site had different regulations on teleconference, teleconference software, and what was allowed by the IRB and what was allowed by the hospital. So it's important to account for flexibility in telehealth delivery platforms, and make necessary changes to our protocol and procedures to match that. Our assessments were developed pre-COVID, obviously, and for us to properly assess the effectiveness of the treatment, and be able to look at factors that influence outcome success, treatment outcomes. We felt that it was important to collect information on the participants' experience with COVID-19, both from parents and from children. So we added assessments to collect data on child and family exposure to COVID-19, financial difficulties and disruptions related to COVID-19, and also the child's schooling experience during the pandemic. The main factors that really influenced recruitment success during this time included state regulations related to insurance coverage for telehealth and clinical care settings. So many, like in Massachusetts, Medicare was expanded to include telehealth delivery of therapy. So that was an important factor in helping us continue.
I want to make sure you get to any key conclusions. You've got about 1 minute.
Oh, I'm sorry.
Since you missed the intro, I wanted to make sure you knew that we were on a tight timeline.
Oh, sorry. I'm almost there.
Excellent.
Awesome. The second was just IRB restrictions on study activities. So we had 4 different IRBs. Our Miami site was incredibly successful in recruitment because they had minimal restrictions on both the IRB end and the state end. That was an important factor. And the last factor that really influenced recruitment success was the clinic's experience with telehealth previously. So we worked with University of Washington for our sites in Seattle. They're telehealth experts. And so the transition for them was incredibly smooth into telehealth, and that really influenced recruitment success as well. So despite these challenges, we really pulled through in the pandemic, and we've reached our 50% goal. We're actually ahead of our 50% recruitment mark, and we're running smoothly. But basically, our big conclusion is really that our collaboration with all study team members, stakeholder groups, and other researchers was really valuable in understanding how to overcome a lot of the barriers that we faced with trying to bring a study that was not meant for a COVID-19 era into the COVID-19 era.
Thank you. That was really fantastic and sounds really familiar. I think Robin's going to talk about this around our project as well, which was also a PCORI project. And my main comment is across all of these various projects, it seems like experience really matters. And what's nice is now a lot of different organizations have that experience with telehealth, with different ways of providing care, and hopefully we can build on that. And so it's really interesting to see that previous experience with telehealth has come up a couple of times as being beneficial contextual factors for COVID-19 related pivots. Okay, Mike, take us to the next one, please.
Thanks, Bethany. And yes, you're right. There's so many themes that are echoed from your poster to this next poster on COVID-induced pivot to virtual shared medical appointments. That's an adaptation we did not anticipate or design for. However, it's beautiful that it worked just fine in 2020 to offer virtual shared medical appointments for several practices. And I don't want to overgeneralize there, but we'll go through the poster here. So Invested in Diabetes, as Bethany said, also is a PCORI project as well, and a pragmatic cluster randomized trial that's testing different approaches to shared medical appointments for type 2 diabetes. And we were going along swimmingly with these traditional shared medical appointments in clinics when COVID interrupted that plan. And there were several practices, actually a group of two systems that were able to, on a dime, shift from in-person shared medical appointments to virtual shared medical appointments. They had some experience, but they were also, they had leadership support. They had some resources to immediately go to at hand for the technology. So whether that be the platform they were going to use to deliver and or some other tools that they were using, including their patient portal, and really optimizing the use of those tools in their shared medical appointments. So in this poster, we've attempted to explore what that was like for both the practice teams and patients alike. So we interviewed patients that had participated in the virtual shared medical appointments, and the practice coach, which was myself and another person, also took notes about all the adaptations and the different changes that took place during this time as well. And those notes were also used to generate this poster. And what we found are that there were several positives of doing virtual shared medical appointments for practice teams. First and foremost, it allowed them to continue delivering services to their patients during COVID. There were about 3 weeks, I think, during March, early April, where patients were driving up and doing some drive-by interacting with their practice team. But this allowed for a group to begin and for diabetes self-management services to continue on during that time. And a lot of practice teams, upon reflecting, would say, I wouldn't have ever thought that our patients would have done that, but they readily did because they were excited to have the opportunity to participate in a group and to continue to work on their diabetes self-management. Patients that could not have participated previously because they were always offered, the virtual shared medical appointments were always offered during work times or clinic times, and not able for them to, or not at times that allowed them to attend. So now that they were virtual and they were offered at different times, more patients were allowed or able to attend, which was fantastic for recruitment and enrollment. I mentioned the use of patient portals for recruitment and messaging for materials and data collection. We definitely have heard that it's nice for patients to have a handbook in hand, as opposed to trying to watch Zoom and then access their electronic handbook that kind of goes along with each one of these sessions during the shared medical appointments. So there's some pros and cons of being able to do the virtual delivery of the actual session, but to have materials in hand was something that patients really preferred. And then also some additional more barrier type of aspects were either patients that could not access, whether that was by Zoom or by telephone, they were not able to participate. And providers' perception of those barriers also mattered. We had a couple of practices that decided not to even attempt virtual shared medical appointments because they didn't think it was a good fit for their patients. And of course, COVID was a stressful time for practice teams. So amid all of everything that was going on in practice, whether that was reconfiguring your clinic so that you were accepting patients and triaging and making sure that everything else was going on as it could for clinic operations, this was added in another layer of planning and implementation that they had not anticipated, but so many of them were able to adapt to. And practice facilitators helped with those transitions to virtual delivery and virtual implementation. Interaction, I want to comment, again, similar to the last poster, engagement is what was described to me as different online. Here in the poster, it says challenging. It may not be challenging as much as it is different. So there's a less interaction that happens for patients and health educators online, which makes it challenging for health educators. They can't read an audience as they do when they're in person. But that doesn't mean to say that the patients are not finding value in the material and in the curriculum. It's as it's been described to me, different, and also a bit shorter. So some quick interview themes that we picked up were, again, that some really valued the convenience. Some were really hesitant to join virtually, whether they used a camera or not, whether they used video conferencing or joined by phone, but many did find it to be valuable. After participating, they were thankful for the experience. And anecdotally, I heard from several practice teams that it was a value add for patients during COVID. There were technical difficulties almost at the beginning of every session, and they worked through them. Everybody persevered, whether it was the health educators and the patients having patience with the mode of delivery. It usually worked out. I think actually more often than not was just a small blip in the overall shared medical appointment. I will mention, I haven't already, this did absolutely change the structure of a shared medical appointment. So the traditional format would have the patient seeing the prescribing provider much more frequently. When we moved to virtual, it became less frequently. And that was due to having a harder time probably coordinating the virtual telehealth visit along with the virtual shared medical appointment. So we had some changes with that, and I think we'll continue to look at what that looked like for this particular group during the year of COVID.
Robin, thank you so much for this presentation. It's, as I listened to you and all the other speakers, it occurred to me, and I didn't even realize this when I looked at the slides in advance, is telehealth really required three things to promote access to care. It wasn't just the research team that had to pivot. It wasn't just the provider practice location that had to pivot, but the patient also had to pivot. And I think as researchers and clinicians, this group of people really came together to facilitate and streamline and make it happen on a dime. All of you really made monumental changes very quickly for the benefit of research and for the benefit of access to care. It's fascinating to put all of that together in everyone's poster.
Can I ask a quick question? So for our study for Invested in Diabetes, we had to get PCORI, our funders, permission to do this and to include these data in our study. Was that your experience as well, Hania?
Yeah, so the funders were definitely pretty intimately involved in this process, and we had to submit like one proposal after another to like redesign the study. But the reality was that we just couldn't do the same study anymore. This had to be a fairly new study, and you know, that was I think the process was pretty long and strenuous, to be honest, and it required us to like spend months just like going back and forth with PCORI trying to figure out what they'll approve and what they won't. So it was a pretty long process, a long journey.
Yeah, that was exactly our experience as well. And you know, PCORI tends to be very rigid and having you stick to a protocol. And so this was way outside their comfort zone, but to their credit, they did allow it eventually. All right, I think we have one more. Thank you, Robin. All right.
Perfect. Okay, good afternoon, everyone. My name is Arla Cohen, and I'm a third-year undergraduate global health major at UC San Diego. Before I begin, I want to thank COPRH for allowing me the privilege to present my poster presentation today. I look forward to sharing my insights with you all. COCREATE stands for Community-Driven Optimization of COVID-19 Testing to Reach and Engage Underserved Areas for Testing Equity. What we stand for is exactly what we strive towards, equity. As we all know, the devastating COVID-19 pandemic struck a little over a year ago, costing the lives of about 3.5 million individuals worldwide. Although inequity has existed within the healthcare system for years, the adverse consequences brought upon by the pandemic has further pushed the healthcare community to work toward closing some of these societal gaps. Socioeconomically underprivileged communities have been especially prone to healthcare inequities, and hence higher morbidity and mortality rates. That is why UC San Diego, San Ysidro Health, and the Global Action Research Center are collaborating to co-create strategies for better testing in the underserved and one of the most impacted communities near us, as well as to understand and address their prevailing needs. San Ysidro is a region of San Diego that is 1 mile from the US-Mexico border. This region faces several inequities in regard to COVID resources, including limited testing, slow turnaround times for getting test results, and lack of testing sites causing residents to travel long distances to get tested. Still, San Ysidro has had the highest COVID positivity rate in the entire San Diego County. Not to mention, San Ysidro residents are especially prone to contracting COVID, given their often multi-generational or limited space housing situations, and economic obligation to continue working despite social distancing orders. These undesirable circumstances have inspired the COCREATE research team to help community members in need so that positive cases can be addressed faster and in community relevant and community driven ways. Today, I will share about COCREATE's efforts to disseminate information via virtual platforms, as this has been an integral part of ensuring community members are fully aware of the positive efforts being made in their surrounding areas to stop the spread of COVID-19. This continues to be monumental in running a well-ordered, community-driven COVID-19 program, as each week our research team updates the San Ysidro community on new relevant information. In order to maximize awareness among our target audience, we established our campaign in 3 stages. First, we selected appropriate platforms and identified strategies to increase followers among our target populations. We established a presence on Instagram, Twitter, and a public-facing program website to reach our target populations of San Ysidro residents, health practitioners, and community organizations through direct messaging and weekly posts. Second, we created and disseminated content in line with COCREATE's goals. Each week, we put out posts that share program information and our collaborative work. We also amplify voices of current San Ysidro community members who share about how COVID has impacted them personally and their community. This serves to expand awareness about the needs of the underserved areas in San Diego and empowers local community organizations to strengthen their efforts to achieve healthcare equity. Third, we adapt and curate online content through constant review of our data analytics. By doing so, we can make appropriate changes to maximize audience engagement. This includes tagging relevant project members and academic and community organizations, including the location, and linking the website to our posts to engage social media users at a greater level. In addition, we have put out more Instagram and Twitter stories, which means users can view the content more times on their feed, as we now share through 2 mediums. Now I'll move forward providing some of our results. As of May 10th, 2021, 4 months after our campaign launch, we have amassed 122 Instagram followers, 14 Twitter followers, and about 1,200 page views on our website. For Instagram specifically, about 70% of our followers are women, and top locations stem from San Diego, Chula Vista, and Tijuana, which are all neighboring regions that are focused at COCREATE. Our data suggests that Instagram enables the greatest engagement with our target audiences. Since Instagram provides more data about what type of users follow our account, it allows us to curate our methods more accurately for higher engagement. We will further investigate additional dissemination strategies to increase our following and thus better promote and carry out COCREATE's mission. In an age where social media becomes more prevalent every day, virtual dissemination is an efficient way to get any message across. An increase in the popularity of virtual modes of communication encourages research teams to think about implementing a stronger emphasis in marketing their mission through virtual means, so the public may become more aware, engaged, and inspired to collaborate. Not to mention, by disseminating essential information via our online platforms, we protect the integrity of our message and ensure our targeted audiences receive news from a reputable source. During the pandemic, conflicting information about COVID-19 was heavily prevalent. The spread of misinformation gives the scientific community even more reason to establish itself as a verifiable source. so as to strengthen the public's trust in scientific research. I encourage you all to engage in these dissemination strategies to promote your scientific works with your respective community members. This way, our communities will be better up to date on relevant scientific research, leading to a more collaborative and trusting environment. Thank you everyone so much for listening, and I would be happy to answer any questions.
Thank you, Ariel. That was really interesting. You talked a lot about the community of San Ysidro as being important factors, social determinants of health types of factors that influence the likelihood of getting COVID-19. Can you talk a little bit about sort of cultural factors in that area regarding communication strategies and channels and what you've learned about how best to reach that community?
Yeah, so as I said, the individuals who live there are in very close quarter living and are multi-generational. So we have young individuals living with older residents. So likely, and then meaning that the spread of COVID-19 is more likely. And I actually have a statistic that the SD County Health and Human Services estimates the infection cause rate in 54 in San Ysidro at nearly 6,000 per 100,000 population, which is 4 times greater than San Diego, the San Diego County average. So in terms of cultural factors, obviously we have a language barrier. So we make sure that we disseminate our information in Spanish and in English. And while we're on site, we have those that are native Spanish speakers on the research team, as well as those that Spanish. Like for example, Spanish is my second language or my third language. So and I knew some from high school, so I was able to remember and still very not too hard to communicate with these individuals. So it wasn't so difficult in that in the language aspect. But I think another cultural aspect is certain distrust in testing. Many people that we've approached have said, I don't have to get tested anymore. I have the vaccine. But we want to make it clear to them that it's still important to get tested and make sure that there's no positive cases still, because as we know, there's people that still get tested positive after the vaccine. So we make sure to take into account to all these cultural barriers. I hope that answers your question.
Yeah, I was also curious that you mentioned Instagram as being the most effective strategy. And I think of Instagram as sort of a younger person's social media platform. Do you get a sense that Instagram is the best way in this community to reach all of those who may be at risk for COVID?
I think so, because I compared, for example, Instagram and Twitter, which are the most popular social media platforms, and I looked up the followers on Instagram and on Twitter, and most of them I wouldn't find. And even like myself, I didn't even have a Twitter account. And I think with another cultural aspect is Instagram is just easier to use and just more popular. So I wasn't surprised by having 100 more followers on Instagram. So definitely. And because like on Instagram, you could see where they're from and their age. It really, really helps, because if I see that I have less women, I could look up on Instagram, like through the location of San Ysidro to find more individuals from that area. And Twitter doesn't give those analytics. They just give like impressions and engagements, which is helpful only to know like if you have like a website and how many times they click on it, or maybe share it to somebody else. So definitely, I think all you guys to engage with Instagram more so.
All right, I'll have to get into that.
Yeah.
All right, well, thank you all so much. This was a great set of posters, very informative, and a lot of sort of similar themes across the various presentations. So thank you all. I think we'll end now, and then we have a breakout session coming up at 2 o'clock. Mountain time.
Thank you.
all.
Thank you.
Thank you.